Hello, hello, everyone, and welcome to the second half of the afternoon. First, want to thank all of our amazing presenters that have gone so far today. We've been covering a variety of topics, and I especially have loved these last few hours from our Women's Committee. Dr. Ross, huge shout out. I apparently need to be doing a much better job in assembling my mentor panel, and so I plan on taking a lot of your tips and tricks back home with me. I'm here to introduce our first speaker this afternoon, a man who needs absolutely no introduction, Dr. Mike Weinstock. To give you guys just a quick intro to him, he is, as most of you guys know, Director of Research and CME at Adena Regional Medical Center, Professor of Emergency Medicine at Wexner Medical Center at The Ohio State University. Risk Management Section Editor for MRAP, has contributed to ERCast, MCRIT, and Risk Management Monthly. And probably the thing that he is known by most of us for is his work with the Bounce Back series of books. Just recently, in February of this year, published Bounce Back's Critical Care, co-authored with Dr. Scott Weingart and Kevin Clower. Dr. Weinstock, your books terrify me. I got one as my residency graduation present. I will admit I've only made it halfway through because every single time I read a case, I get a little bit scared and need time to mentally process it. But all of that being said, these are things that we need to know. And so I'm excited for your upcoming 3 lectures on bounce backs for chest pain, peds, and then critical care. So start us off.
Well, Molly, thank you so much for that introduction. That was very, very kind of you, as well as revealing your innermost fears. So that's not usually normally done at a national conference, but I appreciate that. We all have our own fears, don't we? But, it's good that you mentioned that because 2 things come to mind. First is how we proceed with thinking about bounce backs or even an M&M conference. And Weirs and Nemeth had an article several years ago where they talked about how you best learn. And it's not by thinking about how the practitioner framed a problem that turned out to be wrong, how they framed that clinical situation. It's by thinking about why they thought their decision-making and their disposition and diagnosis was so reasonable at the time. And only by understanding that can you really learn from these cases. And the way that I pick the cases, I want to make sure it's something that's not esoteric, or not something that's obvious. And only by having people say, yeah, I might have handled that case in the same way, can we really get some good education from it. And so I'm going to jump to the punchline with the chest pain. And the punchline is the history. And we're going to talk a little bit more about some pretty in-depth stuff, some recent literature that some people would be familiar with, but maybe other folks won't really be quite as familiar with. And then we're going to sort of go into actually what happened with this patient. So I'm going to share my screen here, and I want to just give a sort of request to everyone. If you could keep this a little interactive, and I have asked Molly, I've begged her, I know she's probably a kinder person than me. So I've said, jump in, interrupt me. If people have questions along the way, I want to hear them. I'm going to ask you a few times to maybe sort of vote and type something in your chat. And so if you don't feel like it, you're eating dinner or lunch, no worries at all. But the more we can keep this just a little bit interactive, the better. That'd be really nice. And so as all my cases are, this case is a true story. And I'm going to start off by telling you the story of Stacy. This is what things might have looked like if we were alive. So anyway, what can I say? This is COVID, right? The year of COVID. So this is the story of Stacy. And Stacy was one of many patients that we see, a 41-year-old woman who presented to the ED with chest pain. But I want to back up just a little bit. And before I tell you our story, as we recorded it on the chart, I want to tell you Stacy's story. Stacy was a working mother, single mother, and she was working poor. She had a daughter and a boyfriend. And when she found out later that her boyfriend was cheating on her, she found out that the woman he was cheating with was pregnant. She was such a kind person that she actually adopted that child as her own. So now Stacy has 2 kids, her own daughter, who is approximately 17 at this time, and then her adopted son, who is around 10 years old. And Stacy was doing her normal thing. She had some medical problems. She also was a smoker, but it wasn't until she started developing chest pain that she decided to seek medical advice. So Stacy presented to the emergency department, and while we're going to keep this discussion focused mostly on Stacy, we're going to have some branch points. And I want to really have an opportunity to talk about the evaluation of chest pain. Now, look, I'll tell you, if you get a STEMI, look, that's very exciting and very concerning, but we know how to do that. And there can be some subtleties, I get it. There can be some timeliness issues, I get it. Maybe even some EKGs that don't seem totally obvious, left bundle, etc. But in general, if we get a STEM, we know what to do. The harder patient is the one that presents atypically, or the one that has some other symptom that we attribute the chest pain to. In fact, if you think about asthma, one of the diagnostic criteria for asthma is chest tightness. So how do we differentiate the two of those, right? So we're talking about some branch points as far as evaluation of chest pain, some in regards to Stacy, some not in regards to Stacy. And then we're also going to be looking at some of the legal considerations in this case, because this case, as you could probably guess, and Molly sort of teed that up in an appropriate way for me to just sort of hopefully hit it even close to out of the park, is that the case did not end well. There was a misdiagnosis, and unfortunately, it did proceed to legal action. So I want to just jump in here, and this is a general slide, but as we go further, this isn't a presentation where it's just a man doctor and female patient. This is actually what the situation was. And I'm going to tell you that the documentation I'm going to give you was the actual documentation. So nothing was changed. Nothing was changed for HIPAA or anything like that. So Stacy presented to the emergency department at 6:13 p.m. And here was her chief complaint as recorded by the nurse, was chest pain. Seems obvious, but then they went on to say pain from above the waist to the head, neck, and arms. So in sort of a funny way, Stacy had pain everywhere above the waist, except for maybe the left little finger, right? However, when you think about a patient's presentation with chest pain, they're asking us a question. And Stacy's question was, is my pain from a heart attack? And I'll tell you how I know that this was her question, because, and jumping forward just a little bit to the trial, I'm going to read you just briefly some of the opening statements from the plaintiff attorney. And they said, "Good morning, everybody. One of the major reasons people come to the ED in the US is because of chest pain. Not all of it's fatal, and it's not always easy to diagnose. And the rule in the ED is you treat chest pain as a heart attack until you rule it out. That's the rule. The evidence is going to show that when Stacy left the hospital with her friend Deneen, they were in shock. Deneen regrets to this day that she did not bar the door and say, no, we're not leaving, but they did." Plaintiff attorney goes on to say, "It's going to be up to you to figure out whether the discharge of Stacy was wrong, was negligent. The failure to even get a basic history was a violation of the standard. We strongly believe that had these things been done, Stacy would be here today and she would be raising her children. Thank you." So we see right off the bat that the plaintiff attorney knows, and I will say, just as a little bit of a sideline, if you don't like a specialist chewing you out at 3 a.m., or if you're a resident and you don't like the attending asking you about something that you did not obtain from the patient when you were actually in the room, you will hate even more an attorney teaching you medicine. And I'm going to give you a couple of examples of that as we go through. But check this out, and this is one of our main initial teaching points, is correlating the chief complaint with the final diagnosis. This final diagnosis was correct. The patient did have hypertension and they did have bronchospasm. And if you look at the attached notes, you'll see the actual chart of Stacy with the actual documentation. And I'll put that up on the slide in just a few minutes here. But the patient came in with chest pain. She asked a question. We know that that was the question in some ways because her friend Deneen, who went with her, said that was the question as well. The plaintiff attorney told us that that was the question. But they ended up diagnosing hypertension and bronchospasm. I'm going to share with you in just a little bit also the medical decision-making out. The bottom line is, and true to form, that the physician did not answer the question that Stacy asked. So I want to talk about three main parts of a chief complaint. One is the patient's question. And for Stacy, it might have been, am I having a heart attack? Or it might have been, can I have some pain relief for the discomfort I'm having? But even if it's some sort of inane type of question, i.e. the 19-year-old who thinks they have lung cancer with their 2 days of cough because their aunt had the exact same symptoms and diagnosed with lung cancer, still, the patient's question is an opportunity for us to engage in healing because reassurance is a part of healing. So understanding their concern is important, but it's not really why we all went into emergency medicine. Totally get it. The second question is, as the patient presents her question or his question, but more importantly than that, it's the question the presentation is asking. So Stacy is asking a question, well, is this discomfort from my chest pain? But the question that we are thinking about is, with chest pain, is this acute coronary syndrome, pulmonary embolism, or thoracic aortic dissection? Or even you could extend it further. Is this pericardial tamponade, attention pneumothorax, or Boerhaave syndrome, and any other life-threatening can't miss cause of chest pain, right? We usually think of the big three and the big six of that, right? So that's the question the presentation is asking. And as we go through the chart, we're going to see that very few, or maybe even none of those questions were answered. The third question is one that we probably don't think about a lot. I want this to be our second main teaching point here, is the patient's understanding of the question that they asked, of the question that their presentation asked. And it's only by understanding that can we have our, as Steve Colucciello from Carolina says, our last chance to get it right. In other words, what's going to have the patient come back in? And of over 60 medical legal cases that I've done as an expert, most for the defense, some for the plaintiff, what I've seen is a big problem is that patients don't come back because they were told in the ER, or at least their understanding from the ER, is that everything was fine. Now, I will say that sometimes we do say that, and sometimes we're correct on that. On the other hand, sometimes there is some amount of diagnostic uncertainty. Don't be afraid of that. Don't be afraid to tell the patient that I don't know. In fact, if you look at the 2018 chest pain clinical decision guidelines from ACEP, this is the national ACEP, they've finally done two things for us. And kudos to ACEP for doing this. One is they've defined an acceptable miss rate, which they say is 1 or 2% missed ACS. And the reason that they say that is because if we try to get lower than that, we're going to cause, and they say, quote, we're going to cause patient harm because of our additional amount of testing. So that's a really, really important thing that ACEP has done for us. The second thing they did is they defined a follow-up time, which is 1 to 2 weeks. Now, in my practice, I've typically done, and the JAMA study that I did on the CRACE outcomes with chest pain looked at an outcome which was shorter than that, 2 or 3 days. However, they have said that within 1 to 2 weeks is an acceptable amount of time to follow up after a negative ED evaluation, where we think the rate of ACS is 1 or 2%. And super important when we're framing that question, we're not sending a patient home and telling them they're fine. We're sending them home and saying that we do believe that your evaluation can further safely be continued as an outpatient. Okay, so we talk about the big three. We talk about the second three. All of these things are things that we're thinking about when the patient asks their question, their presentation of chest pain. And I want to show you now the actual documentation from the history of present illness. And I'm just going to read you just briefly this here. 41-year-old woman with a chief complaint of chest pain for the last 1 day or so we know the duration. A tightness across the chest and upper arms, so we know the character. It's worsened by deep breaths, and it radiates to the left arm. That's really the entire history of present illness. We have some past history, which is great to put there. We have some review of systems, which is great to put there also. But as far as the actual true history of present illness, that's about all we have. As Amal has described, there are 4 things that really have been shown to go along with ACS. Now, this is not PE or dissection, but just if you're thinking of ACS, and I'll add a 5th one onto there also. And the 4 things are exertional pain, diaphoresis, radiation, most specifically to both shoulders, then the right, then the left, at least so, and vomiting. So not nausea, but vomiting. And if you wanted to think about some other things, as far as the other parts of the big 3, PE, what was the onset? Was it sudden? Was the pain pleuritic? In other words, when you took a deep breath, for example, from a PE, were there other symptoms that would lead us to one of these other more serious diagnoses? And we described these 5 symptoms in MRAP's Compendium in the chapter that I did with Barbara Bacchus and Justin Morgenstern, where we talk about those. So I told you I was going to do some branch points, and we're going to jump away from this case for just half a second here. I want to have you, if you wanted to, take a quick peek at a study by Farinoff. And this is part of JAMA's Rational Clinical Examination series, and they looked at the symptoms that go along with ACS. And unfortunately, what they found is that there were not a whole lot of symptoms that you could really hang your hat on. But there were some that had more accuracy as far as ruling in or ruling out ACS. Now, some of the things that would make it less likely to be ACS, like pleuritic pain or sharp pain, just for example, might make it more likely to be still from a can't miss diagnosis like PE. The second one I wanted to bring in is an article by Desmond, also has Alma Mattu and Richard Body, and they look at the history and physical exam and they say, can that rule out ACS? And the conclusion was, unfortunately, it's very difficult with a good amount of patients for that to be ruled out. So look, if you're walking down the street and you get hit in the chest by a baseball, probably that'd be a weird coincidence to happen to have a heart attack at the exact same time. But we need to get those history and physical findings in order to direct our workup, but then we still need to do that workup. And when you think about a workup for ACS, probably just troponin, a patient you might send home, maybe CBC and BMP, right? Chest X-ray and an EKG or EKGs, troponin or troponins. We'll talk about that in just a few minutes with a study by Wassi. But then if you think about the fact that you're rolling out PE, maybe at a dimer or a CTA, right? So you need to get at least additional information to get that. And if you're thinking about dissection, well, then you're really progressing to a CTA of the chest or chest and abdomen, right? And so if you are going to make a decision between these three different pathways, you have to gather appropriate data on which to base your decision on that. Now, the heart score is good, right? Heart score, interestingly, I think we're all pretty comfortable now with low risk chest pain patients with the heart score. And I will say that with the heart score, the initial data from Barbara Bacchus is 1.7% were low risk. There was only one death, tragic, but it was an 18-year-old who ended their own life. It was not a patient who died from a missed MI or a missed cardiac event. The moderate risk, and we're going to talk about that in just a few minutes because that's where a lot of people get tripped up. So we're going to talk about that in a few minutes. But when you think about the low risk and you think about the heart score, we can pretty reliably send home about 31, 32% of patients who will come as low risk. I was able to get the data that Dr. Bacchus shared with me for her initial study in 2013. And we went through it and looked, and we found that of patients over the age of 65, only 15% were low risk because you get two automatically for your age. So, one or two risk factors and a couple little non-specific EKG changes and a moderately suspicious history, all of a sudden you're off and running with a moderate risk heart score. The other thing super important to point out about the heart score is that a slightly suspicious story is a 0 on the heart score. So a lot of people think, well, you're almost automatically a 1 if you're even going there. That's not true. You can get a 0 if your story is only slightly suspicious for ACS. Okay, so what is the risk? What is the risk to sending home a patient where we do gather appropriate data? And I will show you with Stacy, unfortunately, that was not done. But if we do gather appropriate data, what is our risk with a patient who has a negative evaluation in the ED? And this is Paul Hess, different than Eric Hess with the chest pain choice. This is Paul Hess, interestingly enough, his brother, I was surprised to find out, who's a cardiologist. They looked at patients who actually had a diagnosis of NSTEMI, and they found the incidence of sudden cardiac death at 6 months was only 0.79%. It's pretty crazy, isn't it? 0.79% if you have a diagnosis of NSTEMI. Well, think about our moderate risk patients who don't even have that diagnosis. They've had a negative ED evaluation. Can we safely further continue their evaluation as an outpatient in the next 1 or 2 days? ACEP says yes. and I do too, but more importantly, ACEP. I want to also, and this is, I think, the last study I'm going to throw at you here. Actually, one more before this, but I wanted to bring this in. This is the heart pathway study. And then we're going to jump back into our case in just a second here, where they looked at over 8,000 patients at US sites, not sites in the Netherlands. And what they did is they looked at the low risk patients. And I'm not going to go through all of these, but it's interesting to me, and take a quick peek at this article again. This table, I think, got glossed over by a lot of folks. None of these patients would have been either sent home because of hemodynamic instability, et cetera, or would have had their management or outcome, I should say, changed by the fact that they were admitted to the hospital. So take a minute and take a look at these 6 patients, because certainly with their low risk patients, unfortunately, they don't have a table like this for their moderate risk patients. And then finally, a little bit of a controversy, 1 or 2 troponins, this study by Wassi that just came out earlier this year, where they looked at a large group, 27, almost 30,000, almost 28,000 patients. And what they found is several things. One is only about half the doctors did a second troponin. So I think it's hard to say standard of care is to get 2 troponins on every patient. Secondly, in conjunction with the heart score, the clinician can make a decision which can safely send patients home because there was no difference in outcomes as far as MI or death in patients who had 1 or 2 troponins. And then this is also one of the really surprising findings. Of the patients who had a second troponin done, only 1 in 200 had a positive troponin. And Rick Body and Barbara Bacchus and I wrote an invited commentary on that in the JAMA Network Open and sort of reiterated some of those points. So now back to the case. And you're like, Weinstock, it's like we came here to hear about bounce backs, not to hear about all this chest pain data. But I think it's important that we get some context and some literature behind what we're doing and think about some of the more difficult things, such as that moderate risk heart score patient. So I'm going to just show you briefly here and give you an example with this specific case is when I say the physician did not gather appropriate data. Now, you might have a different thought on risk factors, but it is part of the heart score and other scores too, right? Here is the plaintiff talking to the physician. And again, we don't love when other people teach us medicine when they're physicians. We certainly don't love when lawyers teach us about medicine. Let's count the risk factors, the plaintiff attorney says in a condescending way. 1, diabetes, right? Yes, sir. 2, smoking. Yes, sir. 3, hypertension. Yes. 4, stroke. Yes. 5, age over 40 and family history. And the answer is yes to all of those. So we can really probably all at this point agree that when you look at Stacy's chart here, that she has not only a lot of different things that would make us concerned, history of hypertension, a smoker. She, in addition to that, has she has a inadequately done history, but even some things that are suggestive, for example, the pleuritic pain of something that could be something like APE. So when you look at the medical decision-making note, and that's one of the other things I want to really go into, and I can leave a few minutes for questions at the end here, but when you look at the medical decision-making note, to me, this is not, and I've talked about this before at different conferences and on podcasts and all, but the medical decision-making note, the best way we can think about it is a conversation, not a technical thing, not a reiteration of the history, because to me, there's not really a whole lot of room for chart redundancy when we're running around the emergency department and trying to find, 30 seconds to stop in the restroom, right? I mean, we want to make our charts succinct. This is not a novella that we're writing because it's a zero-sum game. There are patients waiting for us, right? But we want to make sure we capture the important part. This medical decision-making note, chest x-ray and EKGs reviewed, albuterol aerosol, captopril, was all stuff that was done, but is documented elsewhere. As far as how this physician made their decision to send this patient home without any troponins and without any mention of chest pain in their diagnosis is still a mystery because that wasn't described. I mean, obviously it's not enough of a mystery that we think that they didn't think that something bad was going on. So you ready for the bounce back? Because this patient did bounce back. That's the title of the lecture. And unfortunately, that's exactly what happened. Stacy went home. She had some intermittent chest pain. At 4 o'clock in the morning, she went outside to smoke a cigarette, and her 17-year-old daughter woke up. She heard something rustling around in the kitchen. She woke up, she sat with her mom, and her mom said something curious to her. She said, if there's anything that I did during your upbringing that I shouldn't have done, or if there's anything that treated you unkindly in any certain way, I'm sorry for that. And her daughter was puzzled because Stacy was the greatest mom of all times. And they all went to bed. And the next thing the daughter remembers is hearing a crash to the floor, performing chest compressions on her own mother early in the morning while she's on the phone with 911. Paramedics arrive and find that she has this rhythm. They intubate the patient, perform all the ALS protocols, take her to the hospital. And unfortunately, at the hospital, despite the fact that she was briefly resuscitated for a few times during the code, unfortunately, she did not make it. And an autopsy later revealed that she died of a heart attack. And she was pronounced dead at, unfortunately, 5:43 in the morning. So what are the lessons from this case? And there are several, and I want to do a higher level sort of discussion on this and to address some questions that have been asked from me when I've had the pleasure of actually being in the same room as you and seeing your facial expressions, and or if like you're sleeping or just clicking on things on your phone, right? Should I document that it's busy? Take a look at this. This was plaintiff exhibit number 1. This is Stacy's triage log. And they were able to bring this up during the trial and show, well, look, Stacy came in with chest pain, but what were you so busy doing during this time? A laceration, abdominal pain, leg pain, sore throat? No, you had an adequate of time to care for Stacy. Secondly, the jury looked at the same case, and I told you I was going to sort of throw this out to Molly. If the folks want to put in the chat, and I think I'm actually able to see the chat. So if you guys want to just sort of put in, and feel free not to do it if it's too much effort, but if you want to just sort of put in the chat what you think happened with the jury, I'd be happy to tell you what actually happened, how this played out in court. And if I'm able to see that, great. Do you think this went for the plaintiff or for the defendant, or you could just think about it in your own mind? And I will tell you, this case ended in sort of a curious way. And this was a bit of a surprise and a shocker during the actual trial, because what happened is the defendant's mother, actually, the defendant physician's mother died a very similar way after the primary care physician said, it's all in your head, this is anxiety. His mother died from a heart attack. He was so racked with guilt because of this misdiagnosis and this outcome, he chose to settle during the trial, in fact, admitting to the plaintiff attorney that what he did was wrong and that he gave bad care to this patient. To which the other defendants, who were other people that were being sued in the same case, because usually there's more than one, sort of cried foul, that's a bell that can't be unrung, but the judge overruled all of them and ended up the case being decided for this plaintiff. And in the end, this is not a case, this is not the type of situation that we'd have wanted any of our family members to get this type of care. So look, there's rare things that happen, and we might sometimes make some very good decisions that turn out to be bad, because we're not expected to be right 100% of the time. But what we are expected to do is to gather appropriate data and then to incorporate into that medical decision-making process that we make in a reasonable way. So in the end, I don't want you to document defensively, but what I want you to do is to document in a way that's defensible. In other words, gather appropriate data, whether it's the exertional pain, diaphoresis, radiation, vomiting, pain similar to a past history of an MI, a past MI that you've had, to think about other life-threatening things like PE or dissection. And if you don't think there are things that are going on, great, but put that in your medical decision-making note, why you don't think a 41-year-old woman who has some other medical problems and pleuritic chest pain is not having a PE. And then finally, if push comes to shove, then you've made that arrangement. You've made sure the patient understands, as Steve Clucciello says, our last chance to get it right. It gives us the opportunity to make sure the patient understands that they can come back, that we have not 100% excluded a life-threatening problem, and that they shouldn't just sit at home saying, I've already been to the ER, they did all the tests, they said everything was fine. Molly, we have about 90 seconds left. My timing hopefully is pretty good here. Do we have any questions, or do you have any questions that I can address in this last little bit of time?
I just have like this never ending sinking feeling in the pit of my gut, because right from the get-go and reading that nursing triage note of pain from the waist up, I know my own inclination is to automatically box this into a it can't be that bad type of category. And it just reminds me of so many times that I've told my medical students, my residents, you always walk into that room with a completely open mind, an open-ended question. You start there. Hey, what brings you into my office today? Because we really, truly do not know exactly what's going on with the patient until we talk to the patient. And unfortunately, I think I took up at least 45 of those remaining 90 seconds. I'm going to hop over to the next session. I'm looking forward to continuing this bounce backs conversation with you here in just a half an hour. Thank you so much for starting.
Thanks so much for having me. It's been an honor.